All right, Unit 1, Part 1. Understand the purpose and the principles of the Medical Schemes Act in the context of the medical schemes industry and environment. So now we look at the knowledge outcomes. People, these 6 are the main headings of this unit, and under each one of them, we're going to look into more detail. So this is the 6 main headings that you need to know with their extra information. So the main heading number 1, we also refer as knowledge outcomes. Understand the reasons for the introduction of the Medical Schemes Act 131 of 1998. So why did it start and it was introduced? Understand the difference between the business of a medical scheme and the business of a health insurance. There's a difference between medical schemes and health insurance. We're going to look into that in more detail. Illustrate the requirements to register a medical scheme. So what will be required to register a medical scheme? Understand the types of medical schemes available. Understand the principle of social solidarity that supports the Medical Schemes Act. And describe the structure and the payment of the prescribed minimum benefits. We're also going to look at that. That's more the minimum benefits available. So, when we look at the Medical Schemes Act 131 of 1998, the people, for the test, I would suggest that you know it's Act 131 of 1998. Because they might ask you, and I'm just using an example, they're going to give you, let's say Act 131 of 1989, of 131 of 1990, of 131 of 1999, or 130 of okay, now we must have one correct one. All of them are. Let's make that one. This one 2002. So then they might ask you, the Medical Schemes Act is which of the following acts? Choose the correct answer. Is it 131 of 1998? No. Is it 131 of 1989? There you've got it. That will be the correct answer. It's not 131 of 1999, so I'll draw a line. It's also not 130 of 2004. So your correct answer will be B. All right, so know that, please. So the purpose of the Medical Schemes Act, sorry for that tongue twister, 131 of 1998, was to address the shortcomings of an old act which allowed for medical schemes to vary benefit levels and contributions on the basis of the age and the health status of members. The old medical schemes, they looked at your age and they looked at your health status of members, and then they decided, yes, they will take you, but they're going to put loadings, or no, they will not take you, whatever. So the effects of the deregulation were the following. Benefits for the elderly were dismissed. Benefit structures attracted the young and healthy members, and high-risk individuals and groups were discouraged from membership by applying loadings to the contributions based on the risk profile. So they said, we are not taking old people, sorry, the elderly people, no, because the health is too dangerous, and higher risk individuals and groups were discouraged. Sorry for my beautiful artwork there. By applying loading. So they will load your monthly premium so much that you decide, no, you're not going to take medical aid. They only wanted the young and healthy members. They said, we'll take you. And those will also. So you see, that wasn't fair to the elder people. There's a lot of elderly people who's still healthy, that runs the Comrades marathons and do all kinds of sports. But just because they were old, they wouldn't allow them. And high-risk individuals as well. So the new Medical Schemes Act of 1998, referred to as the Act, came into effect, and also, know this date, on 1 January 2002. Because they might do the same. They'll ask, is it 1 January 2001, 2002, or is it 31 January of 2000? And it introduced significant changes aimed at reclaiming regulatory authority of medical schemes. The changes included the following. They created the Council for Medical Schemes, which is a statutory body responsible for regulating medical schemes and ensuring compliance with the provisions of the Act. Introduced the concepts of the business of a medical scheme and that of a relevant health service. Introduced the minimum benefits, which are compulsory benefits for all medical scheme benefit options, and they prohibit the discrimination of membership on the basis of age, medical history, or health status. So the Medical Schemes Act cannot discriminate because of age or your medical history or any health status. They have to accept you. In terms of the Medical Schemes Act, there are two types of medical schemes. We talk about mainly the open scheme, and the other one is the closed scheme. Just think of a door. If a door is not open, it is closed. If a door is closed, it is not open. So think of a door. But the other words for open scheme is also commercial schemes. And the other word for closed door is restricted members schemes. So let's look at the open or the commercial schemes with unrestricted. You see, they have unrestricted membership. In other words, anybody can join them. And that is like Discovery Health, Momentum Health, Fed Health, Bonitas, MediHealth, and the rest of them. It's for anyone to join as a member, you see. Anyone can join as a member. That's why it's open, it's commercial. When you look at the closed medical scheme, the restricted one, you see that this one was unrestricted. The closed one is restricted. Why is it restricted? For example, only people that work in the bank employees, may be members of BankMed. I cannot be a member of BankMed because I'm not a bank employee. And some of you will also not be able to join BankMed because you're also not an employee of BankMed. Those of you who are, yes. If you're an employee of a bank, you can join BankMed. So yes. So that is restricted to that company. Like Postmed, the Post Bank, the Post Office employees, they can belong to Postmed. It's only for Post Office employees with their own medical scheme. All right, that is why it's closed and restricted to that group of employees or group of people. A medical scheme has rules regulating the operation of the scheme and specify key aspects such as who may be a member, who qualifies as a dependent, the levels of members, contributions, and which benefits are payable and to what extent. So the medical scheme rules, it forbids medical schemes from excluding applicants or their dependents for membership, except on certain prescribed conditions. Provides for contributions to be determined only on the basis of income and or number of dependents. Improved governance and supervision of medical schemes. Improved financial management of medical schemes. Enable medical schemes to contract with public hospitals for the provision of minimum benefits. Regulates and accredits contractors to the medical schemes, which include administrators, managed care organizations, and brokers. So when you look at medical schemes versus health insurance, do you know what is the difference? So let's have a look. A key feature of the business of a medical scheme. So when you look at the medical scheme, I'll just circle it. The key features is that it indemnifies the members against medical expenses. So the member does not pay the medical expenses incurred in respect of a relevant health service. See, it indemnifies members against medical expenses. The Act governs medical scheme business, while the Long and Short-Term Insurance Act govern health insurance business. So health insurance falls under the Long and the Short-Term Insurance Acts. Health insurance is based on the occurrence of a health event, and the amount of payable must be determined at the occurrence of the event and must not relate to the actual cost of the treatment. A medical scheme business involves the undertaking of a liability to assist in defraying actual expenditure incurred in connection with a relevant health service. But health insurance must pay the benefits directly to the policyholders. You see, medical scheme pay the hospital bill, they pay the doctors, the anesthetists, the surgeon, specialist, everybody, so that you don't have to pay it. You just send them the bills. And the hospital and the doctor or the dentist or the specialist will send the bills and they pay. That's out of your hands, out of your control. You don't have to worry about that. You just say, thank you very much, I've got medical aid. They're paying everything. They take control of the admin and the payments, etc. But health insurance works opposite. Health insurance, they must pay the benefits directly to the policy holder, which means the policy holder must pay the hospital, the theatre costs, and the doctors or specialist /specialist, etc. So that gives you an additional admin job. Okay, that's the difference between the two. Membership of a medical scheme should not be a condition for selling health insurance. So what I mean here is a lot of people said now they're selling health insurance or should not be a condition for selling health insurance. So they say, yeah, they use medical schemes they use medical schemes to sell health insurance. So they come to you and say, listen, I can do medical schemes. Look at this one, look at this one. They cost 1,000 rand, 1,200, 1,500, 2,000. They make an appointment to come and see you. So then they come and see you. Then they said, but I've got a better solution for you. And then they take out the health insurance. Look what you pay for health insurance. 375 rand, 400, 450, 500 maybe, compared to your medical, which is 1,500 or 2,000. So then they try and convince you to rather not take the medical scheme and rather take the health insurance. So they're not allowed to do that. The sales and marketing of health insurance, which make it clear that the product is not a substitute for medical schemes membership. So they must differentiate. They say, sir, and a lot of people don't understand this because they think they've got a medical insurance and maybe they've got the hospital limit of 1 million rand. Now, what if the hospital goes over 1 million rand? Maybe it goes to 1.5. Where are you going to get the extra 500,000 rand? So then people think that if they buy health insurance, which costs them 400 rand a month, then the health insurance will pay that 500,000 in their pockets. And then if the bill goes over 1 million rand, they can claim from the health insurance to pay that. No, doesn't work that way. You cannot substitute your medical scheme membership for health insurance. Requirements to register a medical scheme. So if you want to register a medical scheme, this is what you need to do. This is the requirements. The following requirements need to be met and information supplied. An application to register a medical scheme must be submitted in writing to the registrar for medical schemes and signed by the person wanting to register the scheme. The application needs to be accompanied by all documents and information as required. The name of the medical scheme. A name may not be changed without prior written consent from the registrar, and the rules of the proposed medical scheme that will come into effect at the date of commencement of operations of the proposed medical scheme. Many years, Discovery Health did not exist, and then somebody decided they're going to start their own medical scheme. And so they had to register Discovery, and they had to get all the information. They choose the name Discovery, and they had to get, they cannot change the name without written consent from the registrar. And they had to put all kinds of rules in that, etc. When you look at the requirements to register a medical scheme, the following requirements need to be met and information supplied. Guarantees and guarantee deposits as required by the registrar. So, inform details of the principal officer and the trustees of the proposed scheme. Details of the person who will be the administrator of the proposed scheme, as well as a copy of the administration agreement, a detailed business plan, and the application must be accompanied by the prescribed registration fees. The registrar can also reject an application for registration on grounds of the following. So these will be reasons if you want to start your own medical aid. These will be reasons that they will reject your application. Things like members of the board of trustees and the principal officer of the proposed medical schemes are not fit and proper. So when they are not fit and proper persons, the registration will be rejected. We're going to look later in detail in what you need to be to be fit and proper, if you don't know already. The medical scheme is not expected to be financially sound. So if they see that you're not going to make any money according to your business plan and documents you handed in, they will also reject it. Or if the medical scheme has insufficient number of members who are likely to contribute to the medical scheme. So if they see you're not going to have enough members and who are likely, they're not really going to be able to contribute to your high fees, for example. The medical scheme unfairly discriminates directly or indirectly against a person on one or more arbitrary grounds. So if you can unfairly discriminate and you said, I only want healthy people under the age of 30, they're going to reject that as well. And the registration of the medical scheme is contrary to the public interest. So yeah, that might be reasons. The effect of registration of a medical scheme means that if it becomes a body or a corporate capable of suing or being sued, so it must become a body you can sue or which they can sue as well. Assumes liability for and guarantees the benefits offered to its members and their dependents in terms of the rules of that medical scheme. When they open a bank account to receive contributions and other income, they need to have a registered office in the Republic of South Africa. So you cannot register your medical scheme in another country and run it here in South Africa. They may not carry out any other business except for the business of a medical scheme. That is the rules. Now, I know some of you will say, but what about Discovery Health? But remember, that's Discovery Health. Discovery Health does not sell long-term insurance. That's Discovery Life. They sell life insurance. All right, so that's the difference. It's two different companies. Yes, both have got the name Discovery, but the one is Discovery Health, selling health. The other one is Discovery Life, selling life. Two different companies. You cannot have Discovery Life selling life and health, or Discovery Health selling health and life. No, that's just an example. Okay, so then we look at the principle of social solidarity that supports the Medical Schemes Act. The Medical Schemes Act 131 of 1998, as amended, the Act is based on the principle of social solidarity, which broadly defined refers to the sharing of advantages and burdens equally and justly among a community. The key principles of the Act supporting the concept of social solidarity are open enrollment, it must be open, community rating, and prescribed minimum benefits. And we're going to look at into each one of them. When you look at open enrollment, the principle of open enrollment means that medical schemes have to accept all individuals, irrespective of their state of health or age. Remember, the old medical schemes didn't take the unhealthy people or the elderly, the older people. Now it must be open. You cannot discriminate against that. No one may be declined membership of an open medical scheme, irrespective of their state of health or age, with the exception of specified prescribed conditions. That's the only exception. Specific prescribed conditions. When you look at community rating, the scheme contribution rates are not to differ based on a person's age or state of health, as opposed to individual risk rating in the setting of contributions. Contributions were now to be determined based on income and number of dependents. So that is what they use to determine your contribution. It must be on your income, how much money do you get, and the number of the dependents. Do you have one dependent, two dependents, three dependents, four dependents, etc.? And I know some of you think that, oh, 4 children is a lot, or 5 or 6, but I have friends that got divorced, and now the couple had 3 children and the other couple had 3 children, which is average. And now this couple got divorced, that couple got divorced. Now we've got 2 single mothers, each with 3 children. And then the one married another guy, his wife passed away, and then he and his 3 children were left from his marriage. And after his wife passed away and he went through all his grievings and so on, after I think 2 or 3 years, he met the other lady with the 3 children from her divorce. So the 2 of them got married again, but now they've got 6 children. They've got the 3 children that he got after his wife passed away. So his 3 children that stays with him permanently because it's the only parent left. And then they've got her 3 children from her divorce. So they've got 6 children in the house. So you can imagine what they pay for medical scheme. Monthly payments. It's shocking what he told me. It's a lot. Because it's the 2 of them plus the 6 children. All right. Payment of the prescribed minimum benefits, the PMBs in short. As defined in Regulation 7, the PMBs relate to the costs associated with the diagnosis, the treatment and care of. Currently, there's a list of 271 diagnosis and treatment pairs that must be covered in full without co-payment from the scheme member. All medical scheme options by default have to provide cover for these diagnosis and treatment pairs. Medical schemes are allowed to impose co-payments for conditions not designated as PMBs. I know I have got prescribed medicine, and when I joined my medical aid, my medical scheme, they said for the first 12 months they will not cover it because they can, but after 12 months they must pay that prescribed benefits. Now they are paying for it. Any emergency medical condition, a limited set of 271 medical conditions called the diagnosis and treatment pairs for TDPs listed in the Act, and the 25. There's 27 diabetes, 1 plus 2 plus HIV chronic diseases list called the chronic diseases list or CDL list conditions. So what is the implications of PMBs for medical schemes? The implications of the PMBs for medical schemes are that medical schemes must provide for the full package of minimum benefits in every benefit option. No payment for PMB conditions may be paid from the member's personal medical savings account. So they must pay it from the hospital side, not from my personal savings account. Medical schemes have to pay the full cost of the PMBs from the insured risk benefit of the medical scheme. Medical scheme may apply certain risk management techniques to mitigate the risk of providing these comprehensive benefits to members, including the following: the appointment of designated service providers, requiring pre-authorization for patients with PMB conditions, the use of treatment algorithms or protocols, and the use of medicine formularies. South Africa's public health system. South Africa's public health system is free to all South Africans except for the access to hospital system, which is subject to a means test and free to pensioners, the unemployed, and those earning below 70,000 or with a household income below 100,000. Since the early 1990s, there have been debates about South Africa's provision of healthcare and a need to introduce universal healthcare. The universal healthcare debate has focused around whether South Africa should adopt a national health insurance, or in short refers to the NHI system, a universal system offering healthcare to both those who contribute and those who cannot afford to do so, or a national health service, NHS, a publicly funded and provided healthcare system that is free at the point of service, or a social health insurance, SHI, system for those who can afford to contribute. In 2007, the government decided to work towards an NHI system. So you can see there's three systems. There's a national health or the insurance. So the N stands for national, the I for health, the H for health, and the I for insurance. Then we get the national health service. So the S will tell you it's a national health service. And then we get a service or a social health insurance. And that's the S for social or service health and the I for insurance. That's the three, but our government decided to look at the NHI system, National Health Insurance System. Medical aid contributions. Medical aid schemes must submit their increases to the Council for Medical Schemes, the CMS. That is like the registrar of medical schemes, for approval every year. So every year when they want to uplift their contributions, they want to increase them, they have to send it to the CMS for approval. The CMS is the big voice for medical schemes in South Africa, and they must approve all product changes before the schemes can make them available to customers. So if they want to alter or change the products, they must send it to the CMS for approval. Thankfully, the Council is considering the affordability of contribution increases in light of the current economic climate and the high pressure already on everyday South Africans in their suggested increase levels. For the 2023-2024 medical aid increases, they're suggesting medical aids keep their prices hikes cool, aiming for below the consumer price index, the CPI, at 5% plus utilization. With the average increases plus the utilization margin, we might see hikes closer to 8.5%, so it will be less than 10%. According to the Council, medical aid schemes in South Africa often increases their rates by 3.2 to 3.8% more than what is suggested for reasonable utilization estimates. But if medical aids want to push their prices, they're going to have to submit justification to the Council if they want more higher rates. So what is reasonable utilization estimates? And these are calculated estimations of how much of the fund would be used in the coming year for payouts and medical aid claims from members who are actively using the fund. Membership demographics, current and past claims patterns, and other factors come into play. For example, if the medical scheme has many young, healthy members, they are likely to get fewer claims, and therefore a lower utilization profile and lower rate increases. In 2022, the utilization rate was projected at 3.8%, but for 2023-2024, it's only at 3.2%. The Council also pointed out that medical schemes utilization estimations don't always line up with changes in their demographics and risk profiles. And in these cases, the medical scheme will need to submit detailed analysis with their proposed increase rates to justify them. So when you look at determination of the price of a product, every medical aid in South Africa must be it a Momentum Medical Scheme member or another, starts with a base price to cover prescribed minimum benefits that are required to cover by law. So they must cover the prescribed benefits, minimum benefits by law. So these benefits come at the starting cost of approximately 700 Rand per beneficiary. Mine is lesser than that. On top of that, there are additional benefits, co-payments, those pocket expenses that sneak up on you, and non-healthcare costs that further influence the price. Medical aids also include co-payments and benefit limitations on common cost drivers like scopes and scans, which will help manage the price of the product, but this isn't good news for members as co-payments hurt your pocket. There are also non-healthcare costs that are included in the monthly contributions. These costs go towards administration, advisor and marketing efforts, and also monitored by the CMS. And that's the end of this part 1 of Unit 1. If you've got any questions, please see my email below, there in the middle, jaco@ilearn.co.za, and I will gladly answer all your questions. See you in the next part.